Now, the next family of viruses we're going to talk about are the orthomyxoviruses. And I said that these were the flu viruses. I said of all the segmented viruses, you needed to know about flu mostly because of the segments. Because flu virus can do some genetic manipulations that go back to the fact that it's segmented. Okay? Now, we have influenza A and B. We're not going to talk about C because it's usually clinically insignificant, but we're going to focus on influenza A and influenza B. One of the things I'll tell you now, and we'll talk about it again, is that influenza A, remember A stands for animals. Influenza A infects humans and animals. Influenza B can only infect humans. Now, some of the distinguishing features of the virus are those two glycoproteins in the envelope, the H and N, or the Ha and Na. Hemagglutinin actually binds to sialic acid and allows the virus to get into the cell. Neuraminidase does a few things. Neuraminidase helps to liquefy the mucus to make it easier for the virus to move around. And as the virus is trying to exit the cell, the neuraminidase, sometimes the virus will get stuck on the sialic acid that's around the cell, and the neuraminidase helps clip those newly made viruses from the host cell membrane. All right? Ha and Na are also used to serotype the virus. So you've probably all heard of the H5N1 avian influenza. That is the serotype hemagglutinin H5, neuraminidase 1, H5N1. So that's used to serotype the virus. The reservoir, again, as I showed here, is influenza A, again, in animals and humans, and influenza B in humans only. Transmission of influenza virus is through respiratory droplets, and it can also be through direct contact. And the last bullet point here that I will point out is that H5N1 strain that I talked about, which was avian influenza, was at least one strain of flu that we know of that jumped directly from birds to humans. Now, where else do we see that? We saw that with SARS, where the first case was thought to have jumped from an animal to a human. Now, pathogenesis here is where we're going to talk about a little bit of viral genetics. And as far as the viral genetics are concerned, antigenic drift and antigenic shift are the most important as far as viral genetics, okay? Antigenic drift can happen with any of the RNA viruses for this very reason. RNA polymerase does not have proofreading activity, okay? So when there are mistakes made during replication, RNA polymerase doesn't really have the ability to fix them. So you start to get subtle changes in the antigenicity of Ha and Na, the hemagglutinin and neuraminidase, with antigenic drift. You want to think of it as something that kind of slowly occurs over time, but is responsible for epidemics. People who are vaccinated and antigenic drift has occurred can still get the flu, okay? They may get a little milder version of it, but again, that drift just changing the serotype a little bit so that people who are even vaccinated are not really covered because the serotype has changed. What's much more severe is antigenic shift. This is something that happens really quickly, right? But luckily not very often. Antigenic shift can only happen when you have a co-infection with two different strains of influenza A. So you have some poor bird or some poor pig on the other side of the world having a really bad day, gets infected with not one, but two influenza A viruses. Remember I said you needed to know the influenza viruses were segmented? Well, here's why. You basically just throw a bunch of segments from two different viruses in a bag, shake them up, and now pull out 8 random pieces in a viral capsid, and you've just made a brand new virus, okay? So that's what's happening in here. The segments are all shifting around, and what it's done is created a brand new virus that no one has immunity to. So what you need to know is antigenic shift is responsible for pandemics or worldwide infections with flu. How relevant is this? The influenza pandemic of 1918 and 1919 killed more people around the world than World War I and World War II combined. All right? So pandemics of influenza are really nothing to not be afraid of, but luckily they only happen usually every 10 to 20 years, although we haven't had one in a much longer time than that. Okay? The disease, classic, flu-like symptoms, finally, flu-like symptoms, and you know what? It's actually the flu. Now, you get the general headache, fever, malaise, you're not eating. If you've ever had the flu, you know you've had the flu. It's not just your garden variety upper respiratory tract infection. What happens in kids typically, similar to what happens in adults, but there's usually a lot of vomiting associated with it, as well as some other conditions, including otitis media and possibly croup. What often happens with influenza is you'll get a really sick kid or a really sick senior citizen. They get influenza, you have to hospitalize them, and then they get a secondary bacterial infection. And oftentimes, the secondary bacterial infection is what kills the patient, all right? The flu damages the respiratory tract, secondary infection causes pneumonia, and that's usually the cause of death. Influenza virus is also associated with Reye's syndrome as well as Guillain-Barré. And remember, we talked about Reye's syndrome with VZV, and we've also talked about Guillain-Barré with Campylobacter infections, okay? Now, diagnosis for influenza mostly is done during flu season, which we're taping right now in February. We're right in the middle of flu season. Flu is often overdiagnosed during flu season and underdiagnosed outside of flu season, okay? So season is going to be big, symptoms are going to be big. We also have rapid tests, okay? Serological test, where you can basically just do a nasal swab and you have a rapid test looking for the virus. Now we have two different treatments for influenza, old school and new school. The old school treatments are amantadine and rimantadine that inhibit the uncoating of the virus, okay? The new treatments are the neuraminidase inhibitors, the zanamivir and oseltamivir, which are neuraminidase inhibitors. Zanamivir is an inhaled drug, whereas the oseltamivir is an oral drug. Now, it doesn't necessarily matter which one of those you use, although the neuraminidase inhibitors cover both influenza A and influenza B. But if you don't give those drugs within the first day or two, it's probably not going to do a whole lot for the infection, okay? So you really have to give those up front in the infection, or you're still going to have the flu, and it's not going to really shorten the duration of it very much. Prevention for influenza is, we actually now have two vaccines. The predominant one still is the killed vaccine, where we're going to take two strains of influenza A that were predominant from the year before. We're going to take one strain of influenza B that was predominant from the year before, and we're going to put those into the vaccine for the next year. And generally this works fairly well, except for in the example of drift or shift. The live attenuated vaccine is flu mist. That's the one that's given intranasally. The composition is the same, but you wouldn't give the live attenuated vaccine to young children or the elderly. So a few years ago in the US, we had some vaccine shortages when we had flu epidemics, okay, in the US. And the killed vaccine was almost impossible to get. So a lot of students were getting the flu mist vaccine, the intranasal administration, but small kids and elderly could not get that vaccine because of the risk of it actually causing flu, okay? So we do have prevention. You do need to know about the vaccine. And predominantly, again, the killed vaccine is the one that's really most used in the U.S.